Thank you for the introduction. Good afternoon, colleagues and friends. The topic of my talk is suspected bile duct injury during laparoscopic cholecystectomy. What do I do? I'm just going to start with this statement from the American College of Surgeons, which says that laparoscopic cholecystectomy is a nickel and dime operation, and bile duct injury is, of course, $1 million complication, particularly relevant in the United States. So, two components to this talk. First, we have to confirm the diagnosis, and then next we have to think about management. I'm going to briefly recap what I talked about 2 days ago, how to avoid a bile duct injury, because if you can avoid even one bile duct injury, that's a big step. So, anticipate the high-risk gallbladder patient, infection or small shrunken gallbladder. Don't grab the gallbladder low. Remember that critical view is not always possible, and subtotal is a safe procedure. So, come to the topic for today, injury recognized at operation, injury recognized later. I'm going to use some slides from talks that I've given in Sri Lanka. They have the little sign of Sri Lanka in them because I think they're relevant. Bile duct injury is a specific problem in countries where there are a lot of relatively inexperienced surgeons doing general surgery. So let's talk about a case. This is a 73-year-old taxi driver, 4-year history of recurrent right upper quadrant pain, presents with a fever, tachycardia, no jaundice, tender right upper quadrant. Ultrasound scan shows a thick-walled gallbladder with multiple stones and a trace of fluid around the gallbladder. Bile duct is normal. Liver function tests are normal. White cell count is a little bit elevated. CRP is also raised. So this is the clinical picture of acute cholecystitis, but maybe with a late presentation because he's had his symptoms for 4 years. So the options are conservative management with antibiotics, intravenous fluids and analgesia, plus or minus percutaneous cholecystostomy, and early laparoscopic cholecystectomy for acute cholecystitis. So this is a true story. This is a patient who was operated on in a hospital about 10 miles from Manchester. The surgeon elected for laparoscopic cholecystectomy. So open cut down, carbon dioxide pneumoperitoneum, 4-port approach, 3 additional ports, thick-walled gallbladder grasped and elevated. And then I've copied this from his operation note. This is an old operation note. This is a case from a long time ago. He says, difficult to establish a view of the cystic duct and artery, moderate to heavy bleeding during dissection, possibly arterial. That's always a worrying thing. Callous dissection eventually completed, but because he was uncertain, he opted for an intraoperative cholangiogram. And we don't routinely do an intraoperative cholangiogram, but the surgeon opted for this. So he occluded the cystic duct on the side of the gallbladder, cannulated the cystic duct, and did a cholangiogram. That's the picture that he got. So these slides have got the Sri Lankan College of Surgeons logo just in that corner there, because I use these for teaching in Sri Lanka. And the question I asked the audience, we gave them a green card and a red card, after this cholangiogram, would you proceed to remove the gallbladder? It's okay, you don't have to answer this question because it's a lecture, it's not a question and answer thing. And I think the answer is, it's not an adequate cholangiogram. I think you would all agree with that. So, if you have an inadequate cholangiogram, what can you do to try and make it a little bit better? So if there's no proximal flow, place the patient head down, reverse Trendelenburg, release the clip securing the catheter, withdraw the cholangiogram catheter, refix, repeat the intraoperative cholangiogram. It's almost exactly the same picture. So, is that okay? Is that an adequate cholangiogram? Again, I think you would all answer to yourselves, no. Because it can be the cholangiogram of bile duct injury. You've got a distal picture, nothing else. So, briefly, a little bit about indications for cholangiography at laparoscopic cholecystectomy. 2 reasons. 1, to detect stones. 2nd, to delineate the biliary anatomy. I think these detection of stones indications are obsolete, because if you have asymptomatic stones, they're going to pass. If you have symptomatic stones with abnormal LFTs or jaundice, you're going to know about it beforehand. I think probably the only real indication or the only value of doing intraoperative cholangiography is this one. It might help you to recognize that there's an injury at the time of doing the operation. there's no value in IOC to avoid bile duct injury because you have to make a cut. So you've already made an injury. This is the paper I talked about before, so I'm not going to talk about it a great deal, but it shows from a population-based study that routine intraoperative cholangiography reduces the incidence of significant and severe bile duct injury during laparoscopic cholecystectomy. So let's come back to our patient. This is his cholangiogram. What do we do in this situation? So there's some bleeding. We've got a cholangiogram that looks like this. As the brief of my talk is, what do you do with a suspected bile duct injury? This is now a suspected bile duct injury. So the surgeon opted to convert. When he converted, his operation note says there was a moderate hemoperitoneum. Eventually, he found a duct. He called it a cystic duct, located and cannulated, repeated the cholangiogram. That's the cholangiogram that he got. That doesn't really help because that shows the proximal biliary tree, but nothing distally. So I don't think we're out of the problem situation. What to do in this situation? So in general, you have to try and control the bleeding without causing more damage. You can do a Pringle with a soft clamp. You need to try and identify if there's an injury. So in this case, he phoned us and the patient was transferred to our hospital. He packed because there was bleeding. So this is a CT which we did the day after the patient arrived. You can see a swab in the gallbladder fossa. And then we're not quite sure what we should do. So we made sure the patient was a little bit better, hemodynamically stable. About 48 hours later, we did a laparotomy to remove the packs, and we confirmed that there was a transection injury just below the insertion of the cystic duct with a segment of bile duct excised. So it is an option in that situation to leave the situation alone if the patient is critically ill. My operation note from 13 years ago records this as an E2 injury with a concomitant injury to the right hepatic artery. We treated this with a roux hepaticojejunostomy, which can be difficult because there's a lot of edema. The colon is in place, the duodenum is in place, so it tends to be an anticolic roux loop. Slow post-operative recovery, and the patient was well when last seen in clinic. So that's the case. So in terms of confirming the diagnosis of bile duct injury, what do? We've called for help, we define the anatomy, an intraoperative cholangiogram can help. These are the common scenarios of intraoperative bile duct injury. If there's a gallbladder leak from the gallbladder fossa, I think you have to oversew that, and that can be done nicely laparoscopically. If the right side of the bile duct is damaged, but there's biliary continuity, keep the bile duct intact. You can repair that primarily. You can put an absorbable stent, but they're very expensive. Transection, stable patient, hepaticojejunostomy. Transection with hemorrhage and an unstable patient, then you have to consider just leaving a drain and coming back for a later date. So as I said, don't convert a partial transection into a complete transection because the bile duct has blood supply at 3 and 9 o'clock. And if one side is cut, the other side is usually intact. It may heal as a stricture, but at least there's then an endoscopic option, which is still there. This thing, early versus late repair, it's an irrelevant and obsolete debate in management of suspected bile duct injury because I think what you do is you resuscitate the patient, you get imaging to identify the extent of the injury, and you exclude concomitant injury. So after resuscitation, as we did there, you'd probably do a CT scan first to confirm that the liver is perfused, to exclude concomitant visceral injury. If you think the bile duct is intact, an ERCP, if the CT suggests that the bile duct is not intact or that there's a clip, then we do an MRCP. So what are the options? 3 scenarios. Immediate repair, if it's recognized during the operation, early repair or late repair. Early repair is if there's typically a high volume bile leak, imaging confirms an injury, endoscopic if the duct is intact, or hepaticojejunostomy if the duct is not intact. Late repair is typically a situation you have to think about for an ill patient who is presented late with biliary peritonitis, sepsis, maybe organ failure. In that situation, you have to deal with the sepsis, you have to improve the nutrition, improve the renal function, image the injury, and do a late hepaticojejunostomy. Right at the end, I'm going to talk about Strasbourg's classification. I talked about this 2 days ago. As we said, limitations in my healthcare system, this is a problem to call Strasbourg A a bile duct injury because it's not an injury. Where's the injury? Strasbourg doesn't recognize concomitant vascular injury, doesn't recognize the relevance of the time of injury in relation to presentation. And Strasbourg E, the 5 types, it's much too complex. So A, managed with an ERCP and a stent. B, doesn't need anything. This is where the right posterior sectoral duct is ligated. Most times we don't even notice this. C, where the right posterior sectoral duct, or maybe duct of Luschka if you want to call it that, is open through the gallbladder fossa. One of the things I didn't say when I talked about this 2 days ago is that you can do an ERCP, put a stent in, and the bile leak still persists because it's a disconnected duct syndrome. D is this one which can be managed nicely endoscopically. It may give you a late stricture. You may need to do a late hepaticojejunostomy. And then for E, these a little bit too complex this. So this is an E3 injury. This is not that patient. This is a slightly separate patient. So we do this as an open operation. You can do it laparoscopically, but I would do it open, right subcostal incision. Typically there's a lot of adhesions. Use the falciform ligament and segment 4B to identify the hilar plate. Trace down to the hilar plate, maybe take the hilar plate down carefully. You have to remember that if the bile duct has been excised, the only structures which are present in the hepatoduodenal ligament are the artery and the portal vein. So very easy to damage those. Take care not to damage them. May be wise to put a Pringle sling in place. If you can see even a little bit of bile duct outside the liver, you can aspirate it. If you can't see bile duct, what I would do is use the Kusa to expose the intrahepatic biliary tree. Once the duct is identified, I always try and open the left hepatic duct because there's a long extrahepatic course of the left hepatic duct, and you can put a roux loop onto that, what is called a Hep-Quino approach. So in summary, management of bile duct injury, if it's recognized intraoperatively, as I said before, always worthwhile calling for help. If it's not recognized intraoperatively and it's a late presentation, it's important to resuscitate the patient, improve the nutrition, define the anatomy, and exclude concomitant vascular injury. Endoscopic management is preferred for partial transection. Complete transection requires a hepaticojejunostomy. And as I said here, you can take advantage of the long extrahepatic course of the left hepatic duct. Thank you very much for your attention.